Thank you, Maulik. Thank you, Ritika. Good evening, friends. I am Shrenik from Ahmedabad, Vice Ambassador of Indian Cancer Society, Delhi branch, and moderator of Fridays with Shrenik live webinar. Fortunately, today is our 41st webinar. We are conducting today, and I'm very much pleased to introduce Dr. Suman S. Karan. She is a director and medical oncologist at Fortis Healthcare in Gurgaon, and she is a master experience of about 12 years, and she has practiced in UK as well, and she has a specific interest in drug development pertaining to cancer treatment, etc. So, Dr. Suman, thank you so very much for joining us, and we truly value your time, and we would like your answers. This is the since October is a month of breast cancer awareness, so we took this opportunity to invite you. So welcome on board, and stage is all yours. Thank you once again for joining us.
Thank you so much, Mr. Shrenik Shah, for inviting me here. I mean, you are a true inspiration to, all the, to us as well, to doctors as well, and to the patients. And of course, I think you're leading the way for, making cancer not seem as that scary thing. You're actually helping people navigate through their tough times, and what you keep doing is just simply wonderful. And thank you so much for having me here, and thank you, Indian Cancer Society, as well. Really, Mrs. Josna ji, please, thank you so much for
Thank you
having
so
me.
much.
Yes.
Dr. Suman, once again, we have Colonel Tomar with us. He is a CEO of Indian Cancer Society. He has also joined us today.
Namaskar, namaskar. Grateful to have to be here. And I have a very brief presentation, and then I will take the questions. I'll just share my screen if that's okay.
Yeah.
So I hope my screen is visible.
Yes.
Yeah, okay, thank you. Yeah, so thank you so much for having me here today. I will be talking about breast cancer awareness because October, as Mr. Shrenik sir has said, Breast Cancer Awareness Month is the whole month of October, and today is the last day of October. And I think it would be wonderful to wrap up the month by talking a little about the most common cancer in women, which is breast cancer across the entire world. I'm a medical oncologist, and I practice at Fortis Memorial Research Institute, Gurugram. And I'd like to start a little, by just a very nutshell, what exactly is cancer? Why is it so fearsome? It's because cancer is something which is dysregulated. It does not have any form like a normal cell. It is abnormal in its shape and size, and what makes it fearful is that it grows without control, and it invades into the nearby spaces, and it disrupts the regular tissue action. So there are certain features of the cancer which actually make it so fearsome. One is the capacity to multiply without any check. So it has proliferative signals. When I say proliferative signals, it has a constant switch which is on, and the growth is happening on and on and on. Somehow it is able to evade factors that kill the cell, or factors that help regulate the growth. It is able to evade it completely, so it continues to grow without any check. And the best part about the cancer is that it escapes the immune system. It hides itself from our immunity, so our immunity cannot detect it in our body, and it just sits inside our body and grows and replicates, and it starts producing its own nutritional supply, its own blood vessels. It resists death, and it starts invading and then spreading to the rest of the body. So that is what makes it very it makes it as bad as it sounds. And Cancer cases are rising, and we know that there is a prediction of about 45% increase in cancer risk cases by about 2030. So it is really an epidemic that we really need to take put in our focus, to get more and more people to come to the doctor, to the oncologist at the right time, so that these could be picked up at an earlier stage. Men and women both have a very high risk of cancers. Men, about 55% increase in cases are going to happen by 2030. And in women, it is about 35%. That is almost 2 lakh new cases in women by 2030. And we know across the world, the highest number of cases happens to be lung cancer, but across the world, breast cancer is at number two. When you look at deaths, overall, if you look at men and women together, lung cancer is at number one and breast cancer is at five. This is, I mean, men and women combined together. Um, we know that some of the risk factors for cancer, we know that tobacco is probably the most important risk factor. Obesity is definitely an important risk factor and it's a common risk factor across malignancies. Lack of physical activity, especially, and having a lot of processed food, environmental exposures, pollution, alcohol, and viruses are some of the leading causes of cancer. And now, why in India we should actually look at the epidemic of cancer, and especially breast cancer? Why is there a focus on breast cancer in India? Before we come to that, a little about what exactly is the breast cancer. It is a tumor in the breast. It can be the tumor in the ducts, these little glands here. It can be a tumor which is there in your armpit as well. And when it stays in the breast, it's a local disease. When it goes to the armpit and in the form of lymph nodes, it becomes a locally advanced disease. Once it spreads to the rest of the body, it becomes an advanced disease or stage 4 disease. So, this is how we actually stage the breast cancer. And 1 in 10 women are going to be diagnosed with breast cancer in their lifetime. So, this makes it really a very high chance of a breast cancer in a lifetime of a woman. And that's why it becomes very important for all women to know about this. Now, although breast cancer in men is rare, it still happens. For every 138 women who have breast cancer, you will have one man who has a breast cancer. So, at a glance, if you look at the statistics, in males, while it is lip cancer and oral cavity or lung cancer, which are top in India, I mean, in India and of course across the world as well, breast is number one, cervical cancer is number two, and ovarian cancer is number three. These are the leading causes of death in the women. And in India, if you look at it, it ranks number one in terms of the number of new cases of cancer in the women. You can see this pie chart here. Next is the cervical cancer, and third is the ovarian cancer. So it is definitely something that needs to be taken very seriously, because if it is detected early, it can actually be managed very effectively, and the survivals are very much better. Now, some of the risk factors of breast cancer are under our control and some are not under our control. Um, there are certain risk factors which we can't alter. For example, being a woman, a female gender actually increases your risk of breast cancer, because the breast cancer is much higher in women as compared to men. So you can't alter your gender. So that is something that is unalterable. Reproductive history, again, if a woman, and it is a trend of today's day, that women tend to have children much later on in life because of the jobs and because of the pressures of life. Now the women who used to have children at 24 to between 24 to 28 are now having children between 35 to 40. So when you increase your exposure to estrogen, that uninterrupted is estrogen, you are increasing your risk of breast cancer. Every time you have a pregnancy, you're actually interrupting the estrogen flow in the body, and you're actually protecting yourself from breast cancer. Now, women who have had a menarche, initiation of your periods very early on in life. Like, for example, if a girl had her periods at age 9 and then went on to have a child at 35, your uninterrupted exposure is almost 25 to 30 years in between, as opposed to somebody who has had her periods coming at, say, 14 and had a kid at about 26, 28. So her estrogen, uninterrupted estrogen, is actually lesser. So when you have a periods earlier, the risk is slightly higher. Now we know that certain races, the risks are high, like Ashkenazi Jew, they have a very high risk of breast cancer. Age, we know, though we are seeing that younger women are having breast cancer, the older the woman, the higher the risk of breast cancer. Now, family history and a personal history is something that you can't change. For example, you're born into a family where there is a clustering of breast cancers, your risk is higher than the general public. For example, you've had a breast cancer in the past. Again, your chance of having another breast cancer also increases. It is higher than the rest of the population. We know radiation, we know treatment with steroids, hormone replacement therapies, estrogen therapies actually increase your risk of breast cancer. Um, Now there are some. I did say that there are some inherited risk of breast cancer which runs in the family. So that is your familial or hereditary risk. About 15 to 20% of the women have breast cancer running in the have a risk of breast cancer running in the family, and they're usually associated with these multiple genes that we are which you can see in this graph. So BRCA1 and BRCA2 are the most common genes, but apart from that, we've got many genes. We've got almost about 30 genes which do increase your risk, but BRCA1 and BRCA2 are probably the most significant ones that we should be aware of. When you have genes like BRCA1 and BRCA2, your risk of breast cancer substantially increases, and that automatically puts you at a high risk of breast cancer. If you have none of these, but you have a family clustering of breast cancers, still your risk is higher than a general public who don't have such a history. 70 to 80% of the women, if you look at it, do not have any family history of breast cancer, and they just develop it during their lifetime. Now, there are some risk factors that can be controlled, which women can do to prevent breast cancer. Exercising, controlling your weight, breastfeeding, controlling your alcohol or no alcohol, avoiding hormone replacement therapy, birth control pills, and probably having children at an appropriate time. These are some of the things that women can do to reduce their breast cancer risk. Now, a little about how you can actually screen for breast cancer, and there are 4 important ways. Breast self-examination happens to be something that every woman must do once a month at home, and I'll explain a little about it. A clinical breast examination is something which is done by the doctor. Mammograms and ultrasounds are done at regular intervals, and I'll show you how often you have to do it. Now, breast examination is probably the simplest thing that must be done once a month by women. It takes about 10 minutes, and it must be done from the age of 21. Checking up yourself, checking your own breast, palpating your own breast in this particular manner, standing in front of the mirror, and doing this breast examination at the right time. And the right time is 7 to 10 days after the menstrual cycle in each month. So you pick a day, 7 to 10 days after you complete your menstrual cycle, stand in front of the mirror, feel the breast, look for the size of the breast. If there's any discrepancy, look at the skin of the breast. Is there any dimpling or puckering or changes in the skin? Is there any nipple discharge? Does the breast look different? So palpate it up and down, palpate it as wedges and do circles. And this can be done while you have a shower or while lying down, or with some massage oil. You can actually feel and pick up any changes in your breast even before it becomes bigger and bigger. And this is something, why is this particular thing done? It is done because a lot of women detect their breast cancers when it's already a big size. So this is all about picking it up when it is smaller. When it is smaller, it is easier to treat. And most, it is very important to also know that majority of the breast lumps are not cancerous. 80% of the breast lumps which you feel are usually benign in the sense they're not cancerous. But if you find a lump and it turns out actually unfortunately to be cancer, at least you've picked it up in a very early stage. We know that when we pick it up at an early stage, the overall survival rates are very high. A woman who's picked up in a very, before it actually becomes an invasive cancer or stage 1, survival rates are almost 98.8%. That's huge. That's almost 100%, right? But stage two, as you go down, if you look at this 2, 3, 4, the survivals are actually dropping 93%, 72%, and 22%. So even today, stage 4 people are surviving more than 5 years. But if we could pick up something and ensure 98% survival, why should we wait for it to become a stage 4 disease? So the very important thing is, when do you actually come and meet doctors like myself? So a consultation is actually necessary when the breast lump is firm and fixed. It doesn't move easily in the breast. If there is a lump that you have seen for at least 4 to 6 weeks, and it is progressing, it is increasing in size, it isn't reducing, that means it is something wrong. If there is any changes over the skin of the breast, like dumpling, crusting, dimpling, and puckering, redness, or there's a bloody discharge from the nipple, or there is change in the way the nipple looks, or there is a lump in the armpit, these are actually red flag signs and you need to meet the doctor. But what I really want to highlight here is breast cancer usually is painless. A majority of the time, it is a painless lump. So one must have that red flag sign as well, that it's a painless lump, it is, or it might be a malignancy. So these are various different kinds of breast cancers that you could see. You could see here there's a skin change, as you can notice, and the nipple has actually gone in. Here, this is actually looking very red and angry and inflamed. This is again a type of breast cancer. Here, if you look at it, the skin looks like an orange peel. This is actually the tumor which is there in every little duct of the breast. And here you can see this is something which is, I hope women don't come in the time moving forward in this sort of situation. This is a cauliflower growth. This is an ignored lump, which has been there for a long period of time, and it has reached this size. Now, this is again, I want to highlight that sometimes breast cancer doesn't always have to be like a lump. It can just be like a redness like this. You can see it's a carpet like rash which is there, and there's no distinct lump or something. And here, this is also kind of breast cancer. This is called as inflammatory breast cancer. So we must be aware that, if there's anything abnormal, go and meet the doctor. Now, mammogram is a simple test which must be done at about the age of 40, and this helps detect breast cancer. And there is a kind of scoring. 0 to 3 is, so 1 to 3 is negative. 0 means you need to have that rechecked again. 4, 5, and 6 means it is positive, most likely positive for breast cancer. So the question usually asked is, it is like an X-ray. Mammogram is like an X-ray of the breast. And there's a lot of questions sometimes on what is better. Do you do a 2D or a 3D? And what I always say is, 3D, you always get better quality information. 2D tends to sometimes be overlapped, right? And it is important to know that, both 2D and 3D are good. 3D is slightly superior, but you may not find it in all centers. Wherever there is a doubt, you can always check with a different modality. The guidelines to check for mammogram is from age 40 onwards, and it is done on a yearly basis. And women who have a very high risk of breast cancer must also undergo an MRI yearly after the age of 35. And when I say high risk, it is women who are BRCA1 and BRCA2 positive. They are at very high risk of breast cancer. I want to go through a few myths of breast cancer, and then I will wind up my talk. Only, some of the common myths that you hear is only women with family history of breast cancer are at risk. Now, that is absolutely false, because I've shown you that 70% of the women who are diagnosed with the cancer actually have no major risk factors. Now, a next myth is most of the breast lumps are cancerous. Again, I've told you 80% of the breast lumps that are there are actually benign. They are not actually cancerous. And it is important to do self-breast examination to pick this up. Now, breast cancer is not a curable disease. I mean, this is a myth which a lot of people think. And I would like to say that, 90% of, it is almost 98% actually of early breast cancer are curable. And a lot of times you can even conserve the breast. You don't even have to cut off the breast. So it's all about detection, early detection, and treatment in the right manner. Um, the next myth is only women can get breast cancer. Again, I've shown you that one man is diagnosed with breast cancer for every 135 cases of breast cancer in women. So it can happen in a man as well. And we have a couple of male breast cancers as well with us. Small breasted women have less chance of getting breast cancer. Again, this is absolutely no connection between the size of your breast and your risk of getting breast cancers. There's a breast cancer always comes in a form of lump. Again, this is a myth because I've shown you a picture which said, which actually showed you that it doesn't necessarily have to be a lump. It can be like a skin rash. Now, having a risk factor of several means that you will definitely get the disease. Now, even when you're at a very high risk, if you do the right things and the right precautions, you are actually reducing your risks of the disease. So it's all about getting the right advice for the right sort of situation. Now, father's family history is only important, but mother's isn't. Again, this is absolutely absurd myth. Both the family history of the father's side and the mother's side is very important to understand your risk of cancer. There is another myth that wearing antiperspirants, the deodorant sprays, or wearing a bra increases your risk of breast cancer. Again, I'd like to say that this is absolutely
Ritika,
false. There is no such science behind this. And
Ritika, why have you stopped recording? Huh?
yeah,
You have stopped recording, just check.
yeah, I think the recording has actually stopped. Anyway, I have just two more myths. Caffeine does not cause breast cancer, and annual mammograms do not expose you to severe radiation that will increase your risk of breast cancer. Again, that is false. So, with this, I'll stop sharing, and I've come to the end of my presentation. I'm happy to take any questions.
Thank you so very much, Dr. Suman, for elaborately explaining everything in a very swift and short manner, and especially back with the diagrams and examples. Friends, we are always talking a lot on our social media across various platforms. About women empowerment and women empowerment on social media and across various platforms. Today, we have conducted this particular webinar about breast cancer awareness for simple reason. We would like that women get survive, they get early diagnosis, timely treatment, and then survival rate can increase, and they can lead quality life virtually and professionally. So we have opened the room for the questions, and the important part is this is the best platform where you get expert advice online without sitting in a queue. So please proceed with the questions. Thank you. Uh, Dr. Sumat, that is one question from Deepak Payani. What are the chances of breast cancer of daughter if her mother diagnosed with the pancreatic cancer?
That's a very good question, Mr. Deepak ji. So, the chances of breast and pancreatic are connected if they are BRCA2 positive. So, BRCA2 has breast, pancreas, prostate, and ovarian cancer, four cancers clustering together. So, if at all her mother has been diagnosed with pancreatic and turns out to have a BRCA2 positive gene, then the chances of the daughter having a breast cancer increases. Otherwise, it doesn't increase as such.
Thank you. Chotaji, Priya Parmar, if
Can I
you
can
have
I
to.
just ask something, please, Suman?
Yes, ma'am, please.
And, and I think there is a myth that if a mother or Masi or whoever has breast cancer, that the next generation will get it. I'd like you to bust that myth, please.
Yeah, yeah. So that's a very common myth that you just addressed, and like I'd mentioned, it is not necessary even when you have the highest risk. You know, you have a BRCA1, and when with BRCA1, the statistics are 40 to 80% chances. But then these chances only exist if you don't take the right precautions. Even with the highest risk, with your Masi having it and your mother having it, and then you have done a BRCA and you turned out to be BRCA1 as well. There are ways to reduce your risk. There are screening methods, there are risk reducing surgeries. So it is not necessary that just because you have a family history and just because you have a higher risk, you are going to get it. There are lots of ways in which you can reduce your risk. So it is
Thank you.
definitely a very important myth, yes.
There's one more question. What could be treatment protocols in terms of diagnosis in the breast cancer, like for surgery or chemo, radiation? So, what could be the possible order? Of course, it depends. It varies from patient to patient. But we would like to know more about this.
Sir, actually, the treatment of breast cancer is tailored depending on what subtype it is. So there are four major subtypes. You've got a hormone positive breast cancer, you've got a HER2 positive breast cancer, you have a triple negative breast cancer, and a triple positive breast cancer. So these are basically three growth factors which are present on a breast cancer. And if the ER, PR are the hormone receptors, and the HER2 is a growth factor. So depending on what combination of these three factors, which are positive and negative, you have four different kinds of breast cancers. So the treatments are different for different subtypes. Triple negative is the worst. It has the most aggressive nature. We start, if it is a very early disease, we start with chemo, and then followed by sorry, we start with surgery, and then do chemo and then surgery. But for example, it's a little bigger, it is locally advanced, we always add chemotherapy along with some therapy. So it can be a targeted therapy, an anti-HER directed therapy. If it's a HER2 positive disease, it's called a targeted therapy, which is added on to chemo. We will add immunotherapy if it's a triple negative, and then we do the chemo, shrink the tumor, then do surgery, and then do radiation, and continue the targeted therapy and the immunotherapy for about a year. Now, if it is a hormone positive breast cancer, again, if it is big, we do chemo and then do surgery and then follow it up with radiation and hormonal therapy, which is different. Or if it is small, we start with surgery and then do chemo and then do hormonal therapy. So the therapies are tailored depending on what the subtype is and how big it is and what stage it is. Stage 4 disease, of course, the treatments are different. In stage 4 breast cancer, we have oral hormonal therapy options which work better than chemotherapy, and that is usually offered front. If they are not hormone positive and they're stage 4, the other three subtypes, then we start usually with chemotherapy and a targeted and an immuno. Usually these women never are able to get a surgery done, so we continue it on some form of maintenance therapy and maintain this kind of response.
Thank you. Thank you. By the way, there is one more question from Dimple Prayani. My second question: mother diagnosed with the breast cancer and father diagnosed with the prostate cancer. What are the chances of daughter can diagnosed with any cancer?
Yeah, so if the mother has had a breast cancer, again it depends on whether she has a gene which has caused it, and the father has a prostate cancer. See, again, the cancers at what age they occur in the parent is very important. If the parents are developing it at their advanced age itself is a risk factor. So that generally may not translate in an increased risk of cancer to the daughter. But for example, they are young and one has developed breast cancer and one has developed prostate cancer. It means that there is some genetic risk which is running in each of their family, and it is possible, depending on what gene it is transferred to her. So if she has any high risk gene which she must get, in this sort of situation, we would always advise a comprehensive hereditary genomic panel to see what is her risk. And if everything is negative, because there is a risk of breast cancer and a prostate cancer in the father, her we would always advise a slightly higher awareness of the follow-ups and the screenings and all that. But if she doesn't have any sort of gene, like if she has a positive gene, her risk goes up by 4x 5x. But if it is not, instead of x, it will be 2x. But her risk is slightly higher than the rest of the population.
Thank you. Anyone would like to ask questions?
In the staging,
Yes, ma'am.
do you always consider stage 4 as terminal?
No, no. So stage 4 for a breast cancer, especially a hormone, they are hormone positive breast cancer.
Mhm.
They are living comfortably on oral pills for more than, I would say, 5 to 7 years, more than that. HER2 positive breast cancer women, we know that we are able to, give them targeted therapy for years together. And there are so many good treatments that have come, which especially the antibody drug conjugates, these are newer classes of drugs, which are giving us brilliant responses and sustainable responses. I think at the end of the day, it has to be sustainable.
Mm.
Cancers like lung cancer is just a pill, and they give you over 7 to 8 years of survival, which used to be a killer in about a year. People are living 8 9 years just sitting at home taking the pill, coming for the checkups, and that's it. Colon cancers, we know they're very long term survivors. Kidney cancers, melanomas, even at stage 4, we are able to sustain their response with immunotherapies. So I think saying stage 4 cancer being terminal, I think that no longer holds. We have actually converted it into a chronic disease. But there are certain cancers which still we are, struggling with. For example, glioblastomas. We know there is no such thing as a patient pulling on for a long time. Stomach cancers in stage 4, we know are very difficult. Stage 4 pancreatic cancers are very bad. So there are certain groups of cancers which we know are very aggressive, very resistant to therapy. But having said that, there are a lot of cancers that we're able to give them survivals more than 5 years. And I think that we are now looking at long term survivals. Yeah.
I have one more question, Shrenik. Can I ask now, or is there someone waiting?
I don't know. I mean, please go on.
As women live longer and have good, healthy lives, if a woman gets a breast cancer after the age of 85 or more, what are her chances? Is that something that must be treated, or can it be left alone and let the woman have whatever quality of life is destined for her?
Yeah. No, I mean, again, 85, not every 85 feels old. We
Yes.
have some 85s who are so fit, they're fitter than the 60-year-olds. So I believe, age is a number when you look at it. When I was in Manchester in the UK, we had women at 86, 87 taking, full blown chemotherapy. I had treated a patient at 94 with immunotherapy, and he was so fit. I mean, his fitness went down because of the fact that he was on dialysis, and he finally succumbed to respiratory infection. He was completely cured out of his recurrent melanoma. I mean, cured in the sense, it was all out. It was stable. Everything had vanished. And he finally succumbed to respiratory infections a year and a half later. It was not really related to cancer. But having said that, we know that prostate cancers generally occur at this age, and we treat them all aggressively, and because they live longer and longer. But at the end of the day, quality of life is very important. So if it was, say, a hormone positive breast cancer, and I've done that in patients even younger than 85, like 78 or so, I have left the breasts as it is like that and just put them on hormonal pill if they were a hormone positive breast cancer, and knowing that that
Mm.
pill will take care of her and that'll give her better quality of life. But if it was a triple negative breast cancer and say it was a small lump there, I would, I would probably go for a surgical modality and, at least get rid of it at that point of time if she's fit, and not do anything else after that. But I would, tailor the treatment to the fitness level of the patient. I would
Mm.
keep quality of life as the first thing.
Is that something that all doctors agree on? Because we hear of very old people, 90 years old, 92 years old, who undergo very radical surgery and have, until then, they were jogging along comfortably and then suddenly gone. So rather than that, do doctors take all these factors into account, or is it simply that I can do a mastectomy, I can do XYZ?
Yeah, I think that shouldn't be the goal, that I can do it. Finally, it should be what is best for the
A
patient.
patient, yeah.
Yeah, definitely. I mean, I can't speak for all, but most, or at least the people I work with, generally put quality of life first. And
Mm.
that should, at the end of the day, it has to be that, okay, if I do this, how will it impact their mobility? I mean, I think in elderly, mobility is a very big thing.
Mm.
So, always choosing therapies that can give us sustainable, maybe not the best response, but sustain them until they are there, and not giving, not leading them to be bedridden. I think that should be the
Yeah,
approach.
yeah. Thank you.
Dr. Suman, let me mention that, Josdaji, she's, I believe, 82 or 83
Yes,
already.
she looks.
So,
She doesn't see. She doesn't look 82, 83. So I said age is a number.
So, but age is a factor.
Of course, of course.
Yeah.
I always give a lot of, importance to the age. I have a very senior doctor with me who is undergoing treatment. She's 84. So I have chosen the lightest possible chemo because I said, while you are fit, you are still 84. So I
Yeah.
have to respect your age.
That's just the point, that no matter how you tolerate a treatment,
Yes, yes,
you can't get away from the fact of your age.
absolutely.
uh, Priya Burman, where are you? You don't want to ask any question. Dr. Suman is here.
I think Priya's on a train going to Indore.
Oh, really? Fine, fine. Uh, well, there is one more question, and then, I also want to ask one question. Let me ask the. Let me mention the question. That is another question from the same gentleman. The Bayani, which anti-coagulated treatment. I don't know
I,
if the question is complete or not.
is the question incomplete?
Yeah.
You have to unmute yourself.
I'm unmuted.
Yeah.
But I'm asking, you told me that you are using the anticoagulated treatment. What is that?
No, and antibody drug conjugates. It's called
Okay.
ADCs. So ADCs are a combination of a targeted therapy which is
Uh-huh.
combined with chemotherapy, and they are a molecule that has both. So basically, what it does is it has a target which just goes and exactly to that point where the target is. Once it reaches
Okay.
the target, it releases the chemotherapy right at that point. So this is more very precise, and chemotherapy just kills. So it is target driven killing basically. And these drugs, because they have chemotherapy, obviously they have side effects. They have target and chemo both. So they have a little more side effects than a conventional targeted therapy, but they have actually transformed survivals and they are doing really well. And we've just had our ESMO 2025 where we've had new data, and it's probably, initially whenever a new therapy comes, it comes after, at the metastatic stage for disease. It comes after somebody has failed one or two lines of treatment. It's slowly coming as the first treatment to give, so that you can give the best survivals for all these women. It's transforming the survivals.
I I think it was a CDK 4 by 6, but no, these are some different things.
No, CDK 4 by 6 is the oral hormonal therapy that has already transformed, and that's been with us now 7-8 years. This is new now.
Okay.
This is new, and this is big.
Uh,
This is a big
I have
thing.
to connect with you for this.
Yeah, sure, sure,
So
sure.
I'm a patient advocate now. That's
Okay,
why I'm
that's
asking
actually
all this.
happy to connect, and it's really transforming, and we are expecting it to transform the landscape of cancer patients dramatically. The responses, the readout of the data has been amazing. So,
May I
Really,
ask a question, Mr.
Yes,
Shrenik?
please. Yes, please.
Uh, Doctor, there are new therapies you have mentioned, and we have also started learning it. They are highly successful also, whether they are target therapy or hormonal or immunotherapy. But it is also a fact that they are highly expensive. So, how many of the patients, say the middle class group, I'm not talking of even the lower strata of
yeah,
the society who can have access to these type of therapies.
yeah.
So what is the situation, particularly the elderly?
Elderly, yeah.
Mhm.
So previously, when these therapies came, they were very expensive. Even the CDK 4 by 6 therapies, the immunotherapies, when they came in, the therapies were in double digits, in lakhs and double digits. As it's been there now in for a while now, the prices have come down drastically. So before, I would say the whole therapy would have costed about 45 lakhs in a year. Now it has come down to about 8 to 10 lakhs. I'm talking about the drugs which are the multinational company drugs, not the Indian made or biosimilar drugs, or the what you produce locally. And there is something called as patient assistance program, which is from the government of India, and from the company. It's a tie up from the company and the government of India. So there are certain indications, there are probably some 10 or 15 cancer indications, where when somebody has this and they're eligible for it, they get these therapies at a highly subsidized price. Now, having said that, 10 lakhs can also be very expensive in a year for somebody to pay. Now there are molecules which have come from China. When we say Chinese, everybody always, frowns upon, oh, it's Chinese. No, but they are actually 10 years ahead of us in terms of technology, and their immunotherapies are very strong, and they are already approved in the Europe. Of course, US and China, they will never see eye to eye, but in the European market, they're already there. They're here in all the Central Asia markets, and they're already here in India, and they are very subsidized as compared to the drugs that we had from the US or from Germany. They're quite subsidized, and they're quite easy on the pocket. So now I would say that the accessibility to all these therapies are much higher than what it was. Even the CDK4 inhibitors, I remember when it came out, it was almost a lakh or so. Now it is almost about 40,000 rupees for the therapy. So things are getting better. Uh, Now, but I'd like to add that ADCs, this newer class of drugs, they are expensive because they are new, very highly technology. There's a lot of technology that has gone into it, and right now across the globe, they are expensive.
Right. Thank you.
Dr. Suman, as you speak, I think of something else to ask you.
Yes.
So please bear with me.
No, no, no.
One hears that immunotherapy drugs, no one can predict how they will react on a patient until that person has had 3 or 4, 5 shots of it. And then the doctor might find it makes no difference, so why continue? In the meanwhile, that patient has spent a quite substantial amount of money. So, is there I mean, how does one marry these two things? It's not just cost, it is
Yeah.
how a patient reacts.
Yes, no, that's a very fair question, and that's a really good question that you've asked. See, as of today, the only way to predict a response is when you do a scan.
Mm,
There are like we are doing it. We do something called as next generation sequencing, where we look at whether the patient actually. And again, these are not approved yet because it involves a lot of money. That's why the tests are expensive. We study the patient's tumor and we study there pathways in the patient's tumor that make them resistant to immunotherapy upfront.
mm,
But this is not a routine practice because each the test itself is 3 lakhs,
mm, mm,
and you may not get anything in that test as well. So the unfortunately, as of today, until we have, science moves forward and we actually have certain ways to find out, there is no way to predict. It's the same with the chemotherapy. There's no way to predict somebody's tumor is going to react or not. We have to give at least 3 cycles of chemo and immuno to actually do, have enough in the body and then do a scan and then find out. Now, some tumors you are lucky in the sense, say for example, ovarian cancer or like a pancreatic cancer or a colon cancer, you have tumor markers. So you can just look at the pattern of the tumor markers dropping. But many cancers, we don't have any indicators, and the only
mm.
indicator is a scan after 3 sessions. So, as of today, I mean, it has happened with my own very close friend's father did not respond to immunotherapy and in a liver cancer, and we know liver cancers respond very well. Second cycle didn't respond, started going down. I got that test done, and we found out that he had some pathways which made him resistant to the immunotherapy. That is why he wasn't responding,
Mm,
and he finally succumbed because you get a very small window to treat them,
mm,
and the
mm,
treatments ahead were more toxic, so he couldn't deal with it.
mm. Very
It's difficult.
complicated.
Yeah,
Yes.
it's not. I think maybe we will probably have this in the future, an answer when the science develops, but not today.
Uh, any new question? Because
Uh,
I work. Yeah,
Doctor, it's not really connected to the cancer treatment per se, but my question is, asking you as per your profession, is a medical oncologist handles all the type of cancers normally?
Yeah, yeah. A medical oncologist handles all the medical part of the treatment of all the cancers. So we don't do the surgeries and we don't recommend the radiation, but we probably plan the therapies around. We plan the sequence, then we deliver the chemotherapy, we deliver the immuno targeted hormone. That all comes under us. And I mean, we probably direct the patient as, okay, now you have to go for surgery, and now you have to do radiation, and now you. So that's also our role. That's what essentially a medical oncologist does.
So
uh,
right from the biomarkers and all, you are
Right
able
from the
to.
biomarkers. So we generally deal with the biomarkers ourselves
Okay,
and the NGS and all the special testing we do, interpretation and all that.
good, good, good.
let me add to what Dr. Suman has said. When surgical oncologists, radiation oncologists, when they realize that they cannot handle things so well, then they usually guide the patients to approach medical oncology so that various kind of treatment protocols can be taken care of. So I mean, in too many instances, when patients are approaching, usually I straightway guide them to go to the medical oncologist and then let them decide what is to be done, what is not to be done. So apart from surgical oncologist, I mean, I'm having a lot of connection with surgical oncologist, but my prime focus is always with the medical oncologist when it comes to treating patients. So that their role is, I mean, remarkably pivotal.
Thank you. I mean, everybody's role is important, but I think it's all about, sequencing in the right manner so that you get the best benefit.
Right. Now if there is no other question, I have a very important question. to ask Dr. Suman, see, because of either fear or because of some history in the family, you know, just for the sake of precaution or safety, I don't know. I would not say this as a fashion, but at times people opt for a double mastectomy. So, is it really worthwhile, or it is a fashion, or what exactly it is?
That's really a very difficult question, Mr. Shrenik. So, because double mastectomy is recommended when you are BRCA1 positive. It is recommended as one of the risk-reducing surgeries. Both BRCA1 and BRCA2, BRCA1 more often, and we know Angelina Jolie has got both her breasts removed because she has a 40% chance of developing a breast cancer. Now, these breast risk reducing surgeries are very important, especially if you're BRCA1 positive. Otherwise, uh, today there is a different thought process. Again, in the guidelines, if you look at the guidelines, the surgeries are still promoted, but there is a different thought process because science is very evolving now and we've got better screening techniques as well. So today you have both the options of doing a close screening as well versus a mastectomy, bilateral mastectomy. So you have both the options today. But at some time ago, you had only one option. But if you personally ask me, I still promote risk reducing surgeries, and because reconstruction can always be done. But getting a cancer is not something which is very pleasant. So I still recommend surgeries.
Yeah, thank you. And during one of my presentation in AIMS, I did mention that survival is like similar to building legacy. So if you survive, then everything can happen. So you very rightly addressed my question. Thank you so much.
Thank you. Thank you.
Jyotaji or anyone else would like to ask, else we'll start wrapping up the today's session.
No more questions, but just a plea. Do you talk about screening to all women? I think we need doctors to pass that message that breast self examination, clinical examination, even what you call it, a mammography at the correct times is the most important step to prevent breast cancer.
I try, ma'am, wherever I can. I definitely, and we do these, little camps and little awareness programs as well as even in colleges as well, schools and
Mm,
colleges. We start as early as those. So
yeah,
try to do it.
yes.
Yeah.
All right then. I think this is all for today's session. Dr. Suman, thank you so very much for sharing all your knowledge, experience, expertise with everyone present today and answering all our questions so meticulously and in a methodical and I would say authentic manner so that people don't get misled at any point of time. So thank you once again. I'm deeply grateful on behalf of Indian Cancer Society Delhi and myself for taking our time and joining us today. Thank you so very much and have a great day and wishing you a lovely November.
Thank you so much for having me.
Thank you, Dr. Suman.
Thank you. Thank you. Thank you so much, Mr. Shanik,
Bye
sir.
bye. Bye bye.
Thank you.